Gastroesophageal reflux disease. The Montreal consensus definition is effortless movement of stomach contents into the esophagus which causes troublesome symptoms and or complications. The typical GERD symptoms are heartburn, esophageal pain, and regurgitation. Supragastric and gastric belching can trigger a reflux, but belching can also be a behavioral syndrome. Atypical symptoms include chronic cough, wheeze, and these, if only these are present, there is a lower likelihood that GERD alone is present. Dysphagia can result from GERD, but primary dysphagia and bolus impaction without a heartburn, we think of other things like eosinophilic esophagitis and a motility disorder. The Lion 2.0 consensus states that LA grade B, C, and D, or a biopsy proven Barrett's, or a peptic stricture, conclusive evidence that there is GERD. Anti reflux barriers. First, the lower esophageal sphincter. This is the distal 3 to 4 centimeters of the esophagus. Its proximal 2 centimeters is above the squamocolumnar junction, and the distal 2 centimeters is inside the abdominal cavity. The resting LES pressure is 10 to 30 millimeters of mercury. It remains tonically contracted in the fasting state. It lies within a hiatus that's created by the right crus of the diaphragm and it's anchored by phrenoesophageal ligaments. Secondly, the diaphragmatic crura. This is the extrinsic sphincter that squeezes the lower esophagus. The angle of His. This is the oblique entrance of the esophagus into the stomach that creates a sharp angle on the greater curve aspect of the JE junction and causes a flap valve effect. Then there is esophageal acid clearance. One is by saliva, gives a chemical clearance because saliva is full of bicarbonate neutralizing the acid. And then there is a volume clearance by primary peristalsis, which is initiated because of swallowing. Secondary is not by swallowing. And then there is gravity in the upright position. Mechanisms of GERD. One, and the most important, transient LES relaxations. This is the most common mechanism. It occurs independent of swallow and it's not accompanied by peristalsis. It lasts more than 10 seconds of a swallow-induced LESR. It accounts for 50 to 60% reflux in a healthy adult and 60 to 70% in a GERD patient. Swallow-induced LESR, or lower esophageal sphincter relaxations. This accounts for 5 to 10% of reflux episodes. It's accompanied by defective peristalsis, and it's more commonly associated with hiatus hernias. Hypotensive LES pressure, when the LES pressure itself is less than 5 millimeters of mercury. When there is a strain, like an increased abdominal pressure, like in coughing or vomiting, this triggers a reflux. It's more commonly seen with hiatus hernias, and it's usually in end-stage scleroderma or after a myotomy that it's so low. Severe esophagitis would be seen. The mechanisms of reflux in a hiatus hernia. Proximal displacement of the LES into the chest, so that intra-abdominal part would not be there, and therefore the basal LES pressure itself would be low. There is no increase in LES pressure during straining. There is increased transient LESRs during gastric distension with the gas, and the acid pocket itself is increased. Therefore, the reflux during a swallow-induced LESR, and there is reflux during swallow-induced LESRs and transient LESRs. Hiatus hernia more than 3 centimeters especially is prone to a reflux. Acid pocket. This is the unbuffered zone in the gastric cardia which remains low in pH after a meal. This is more common and larger in a GERD patient, especially with a hiatus hernia. The gastric factors causing a reflux would be If there's more acid secretion plus pepsin, not acid alone, but acid plus pepsin, damages the esophagus to a greater extent. Increased duration of acid exposure causes increased risk of Barrett's. H. pylori infection, if it is present in the corpus, it's associated with an alkaline pH, and elimination actually increases the risk of a GERD. But if the H. pylori is present in the antrum, this is associated with increased gastrin and increased acid, and elimination actually reduces the risk of a GERD. Delayed gastric emptying, as in gastroparesis, seen in women and in diabetics, is also a risk factor for GERD. LA grading, the Los Angeles classification of GERD. Grade A is one or more mucosal breaks that are less than 5 millimeters long and they do not extend between the tops of the mucosal folds. Grade B would be one or more mucosal breaks of more than 5 millimeters, but they do not extend beyond the tops or between the tops of the mucosal folds. C would be one or more breaks which are continuous between the tops of the mucosal folds, but they are less than 75% circumference in diameter, in occupation. D would be one or more mucosal breaks and they would occupy more than 75% of the circumference. Now, according to the new Lyon 2.0, B, C, and D are erosive GERD, but grade A is not considered GERD and it needs evaluation. Erosive esophagitis is usually in 6 to 15% of patients presenting with symptoms. The gastroscopy challenges are fasting. The patient has to be fasting. You need to have a skilled doctor. The patient should be ideally sedated because otherwise you don't get a good picture. And ideally the patient should be off a PPI for 4 weeks. In an OGD, you can measure the hiatus hernia. A biopsy is usually not recommended just to diagnose GERD unless you suspect an eosinophilic esophagitis and in the presence of a Barrett's. pH impedance testing is the gold standard. 24-hour recordings can conclude whether it's acid versus non-acid, functional heartburn, and you can do it on or off a PPI. HRM is actually an adjunct. They do it before a surgery and to rule out achalasia. The diagnosis of GERD in pH metry would be an abnormal pH 1, that is less than 4. More than 6% of time acid exposure time. And more than 80 reflux episodes. The diagnosis of GERD would be LA grade B, C, and D, Barrett's more than 3 centimeters if biopsy proven, and peptic strictures. Any of these. In the PPI trial, it was assumed that all reflux was due to increased acid. It had a limited role in the diagnosis because only 69% turned out GERD, 31% were not GERD. Who could we try a PPI trial on? Young people with a trigger and classic symptoms. But we do an OGD straight away if longer duration symptoms, there are no triggers, and it's an older patient. The dose we give is an equivalent of esomeprazole, 40 milligrams a day for 2 weeks. If there is success and there are no troublesome symptoms at the end of treatment for more than 2 days, we call it presumed GERD. Diamond study used reflux disease questionnaire that had a sensitivity of 62%, specificity of 67%, positive predictive value of 92%, but a very low negative predictive value. The PPI trial for 2 weeks, 54% sensitivity, 65% specificity. And there was an overlap with GERD of eosinophilic esophagitis, reflux hypersensitivity, gastroparesis, and functional dyspepsia. OGDs are usually normal in 60 to 80% of patients presenting with GERD symptoms. But we still do endoscopy if we're suspecting eosinophilic esophagitis or a complication of GERD. The treatment of GERD. If there's mild GERD, the general measures, antacids, alginates, and if it's ineffective, we put them in H2RA for 4 to 6 weeks and then a rescue PPI for poor symptom relief. Or we can start with a PPI and then step down to an H2RA. But if there's severe GERD, like in B, C, or D, in B, we give PPI for 8 weeks. In C and D, we have to give them PCABs and then wean off to a PPI and then to an H2RA. Neuromodulators like TCA and SSRI can be given in functional esophageal disorders. Approach to a patient with presumed extraesophageal GERD, like the patient presents with cough, which is dry and persistent, worse at night, or a wheeze or a voice change. According to AGA 2023 guidelines, if there are extraesophageal reflux symptoms and there are typical GERD symptoms, you give them PPI BD for 8 to 12 weeks. If there are no typical GERD symptoms, we submit them to an ENT pulmo workup, chest x-ray, laryngoscopy, and if that is negative, we do an OGD and that is negative, we submit them to ambulatory reflux monitoring of the PPI for 2 to 4 weeks. Then what do we do? So if the patient has typical symptoms of GERD and they respond to the PPI that you give them for 8 to 12 weeks, you reduce the dose of PPI to the lowest effective dose. If the symptoms persist despite the PPI, then you do an OGD. And if the OGD is normal, you submit them to ambulatory reflux monitoring of the PPI for 2 to 4 weeks. And if that shows a positive response, you optimize the anti-reflux measures and the PPI. And if there is no response, you consider pH impedance testing on the PPI. And if that is negative, you treat for functional dyspepsia, and if it is positive, you consider them for surgery. Non-erosive GERD. If the patient has symptoms of GERD with a normal OGD and they respond to PPI. Esophageal pH testing identifies 3 types of non-erosive GERD. One is increased acid with a response to PPI. 2 is normal acid reflux parameters, but good correlations between symptoms and reflux episodes. That's non-acid, in which there is hypersensitivity, reflux hypersensitivity. And this is seen in 30 to 50% of GERD patients. Then you have the normal acid exposure time and a poor correlation of symptoms to the reflux episode. This is functional heartburn. The patient is usually female, and there is no hiatus hernia and thinner patient if the patient has a functional heartburn. Complications of GERD. Hemorrhage. In 7 to 18% patients, there is anemia. Perforation if there are deep ulcers, and this is very rare. Peptic strictures can be seen in 7 to 23%. This is seen in older men and is linked to NSAID use. Peptic stricture patients usually have a better appetite, symptoms of heartburn reduce, but there is dysphagia to solids. Peptic strictures are smooth-walled, tapered, and circumferential narrowing in the lower esophagus. It's usually less than 1 centimeter, but can occasionally reach up to 8 centimeters. If that is such a big stricture, we consider Zollinger-Ellison syndrome and pill esophagitis. We do biopsy if we want to rule out eosinophilic esophagitis, a Barrett's, and a carcinoma. Things that increase the LES sphincter pressure are gastrin, motilin substance P, beta blockers, alpha agonists, protein intake, baclofen, cisapride, antacids, domperidone, and histamine. But things that reduce the LES sphincter pressure would be CCK, secretin, somatostatin, VIP, beta agonists, like your Astelin inhaler, alpha blockers, fat chocolate and mint, CCBs like nifedipine, diltiazem, morphine, diazepam, and barbiturates. The problems with PPI given in the long term. 4-fold increase in fundic gastric polyps due to parietal cell hyperplasia. Increased risk for enteric infections. The relative risk for chronic PPI users is 1.89. There's increased risk of Salmonella, Campylobacter, and Clostridium difficile. Malabsorption of calcium, magnesium, B12, and iron. Osteoporosis happens in 5 years with an odds ratio of 1.62. Acute interstitial nephritis can occur with a PPI. Adverse cardiovascular events if clopidogrel plus omeprazole is used. Lansoprazole or esomeprazole is used. That is, if you combine clopidogrel with any of these, it showed increased cardiovascular events. Endoscopic treatment for GERD. Stretta. Heat generated by radiofrequency wave causes local inflammation, collagen deposition, and muscular thickening of the LES. This decreases the GE junction compliance, so it doesn't move so much, but that is without fibrosis, and therefore reduces the transient LES relaxations. In a meta-analysis done in 2012, the D-Meester score reduced from 44 to 28, and there was better heartburn score with a Stretta. Then there is the TIF procedure, which is transoral incisionless fundoplication. We use esophageal X device. We reconfigure the gastroesophageal valve by a series of plications. 60% of non-responders to PPI reported no regurgitation after 6 months of the TIF procedure. The ideal candidate would be a patient without a hiatus hernia or a grade 1 or 2 Hills and good esophageal motility. The ARMS procedure is anti-reflux mucosectomy. 1/2 to 2/3 of the circumference of the cardia undergoes a crescentic resection either by ESD or by EMR. And the idea is to cause an inflammation causing a fibrosis. The study shows that 55% could stop the PPI in 2 months of the procedure. The best candidate would be those without a hiatus hernia. The MUSE procedure, or the Medigis ultrasonic surgical endostapler. There is direct visualization of the stapler site. You can assess tissue thickness by an ultrasound before doing the stapling. Zachary et al. Study showed 2/3 of patients could discontinue the PPI at 6 months. Surgical treatments for GERD. Laparoscopic fundoplication. The complications include, if there is a wrap that is too tight, the patient can have dysphagia. Displacement can occur. Paraesophageal herniation can occur, recurrence of symptoms in 10 to 15%, and vagus nerve injury can occur. The surgeries are Watson surgery, which is a 180-degree fundoplication, Nissen's, which is 360-degree fundoplication, and a Toupet, which is 270-degree posterior fundoplication. Then there is a link reflux management. A ring of small magnetic titanium beads are placed laparoscopically around the lower esophageal sphincter. This keeps the LES sphincter closed at rest. And during swallowing, the beads separate to allow passage of the bolus. 83% had more than 50% reduction in symptoms.